Let me introduce Dr. Ramchandani. So I'm giving a little background on how this kind of came about. So we'd been using the guidance system to do translumbar embolization. Mahesh and I happened to be in clinic at the same time. They said, I got this lung nodule to localize. This is going to be really hard to find. Can you help me localize it? And, well, I'm a vascular surgeon. Never actually done it, but very excited about the opportunity. Let's see if we can do this together. So he's going to kind of tell you about that journey.
Thank you. So so that is in fact how this began. This project began, and I don't think I think we were the first people to actually do this. It's a good example of how communication between colleagues. You just don't know what's in the other guy's toolbox. So I'll talk to you a little bit about extended use of the hybrid room for lung nodule localization, and try to impress on you why I think this is actually a very important thing, given where we're going with screening for lung cancer. So the current CMS guidelines for screening for lung cancer are that anybody aged between 55 and 77 who's a current smoker or who's quit in the last 15 years, or in fact has a 30-pack-year history of smoking, will be approved for low-dose CT scanning for lung cancer detection. This actually came into effect within the last 5 years and has led to a very large increase in the number of CT scans being performed for lung cancer screening. And as a result, a huge increase in the number of patients that are being sent to cardiothoracic surgeons because of solitary nodules that have been picked up. Many of these, of course, are benign. Now, lung nodules below the surface of the lung, below the surface of the pleura, can't be seen. And so the only way to take them out is to actually get your hand in there and feel for where it is. Meaning, you cannot use, or it's very difficult to use, a thoracoscopic approach or a minimally invasive approach, because when you put the scope in, or whatever other type of imaging system you're using, what you're seeing is the surface of the lung, and you really have no way of appreciating exactly where this nodule is. You can know approximately where it is, and if you do know that, and it's close to the surface but not at it, in order to be certain that you're resecting it completely, you would have to take a relatively large section of the lung out. Other than that, you'd have to make the incision bigger to actually get your hand in to palpate and feel where the nodule is. Now, an image-guided strategy helps to overcome this hurdle, and traditionally what we've done is we've sent the patients to radiology where they get a CT scan, and they get a CT scan guided localization, either by means of a methylene blue dot that's placed on the surface of the lung, or by a breast localization needle. Then they come back to the pre-op area, and then they go to the operating room where the surgeon then performs the procedure to resect this nodule. What we did was come up with a way to extend the use of our hybrid room and combine both these steps into one step. So the patient would no longer have to go to radiology, come back, and then go to the operating room. All of this could be done in one setting. What you do is, and I'll show you several pictures, but broadly, the patient's in the operating room and is positioned as you would for removal of the lung nodule. You create a cone beam CT scan in the hybrid room, and the difference between a cone beam CT scan and a regular CT scan lies in the grayscale resolution. You have better grayscale resolution with a regular CT scan, which means for imaging solid organs such as the liver, a regular CT would be better than a cone beam CT. But in this case, we're looking at nodules that are located within the lung, but the difference in Hounsfield units between air and the nodule is sufficiently large that they are very easily distinguished by a cone beam CT. Now, resolution, spatial resolution with a cone beam CT is in fact better, slightly better than it is with a regular CT, so there's no issues with resolution. So you create the cone beam CT, and then you plan needle access to the lesion, use a needle guide, a single needle guide, or an eye guide, which is a laser that basically marks the spot where you need to introduce the needle, advance the needle to the target, secure your breast localization needle on the target, and then create a targeted minimally invasive incision You look down at the lung, and you don't see the nodule, but you see the needle going in to the lung, and you know from your imaging how deep it is, so you can plan your resection in that manner. So you position the patient. In this case, the patient has a right-sided lung nodule, and you position them as you would for this approach. It's important that you check the C-arm sweep to make sure that there's no potential obstruction that might occur, for example, from the line setup. And this actually takes a little bit of work. You would then perform a cone beam CT, which is basically a rotational CT using the C-arm. I think it's a 270-degree sweep, is it? 200-degree sweep, yeah. And the other difference between a cone beam CT and a regular CT is that it doesn't give you a CT scan of the entire patient, but a more targeted area. You need to make sure that you've got the right equipment. This is a coil that we use in our technique to drop into the lesion, a breast localization needle. You need to make sure you've got the right length. This is a C-star needle stabilizer, which is something that you place on the skin of the patient. And what it allows you to do is to find the exact angle that you need to be advancing the needle in and lock the hub in that position. So the needle can then move in and out freely, but it won't move in any other plane because the C-star guide locks it in that position. Once you've localized the needle and localized the lesion, and here you can see this is a nodule that's a subpleural nodule. You use the laser, which is built into the actual head of the zygo, and it targets a spot on the skin where you need to place the C-star guide. You can then advance the needle, knowing exactly how deep you need to go, because the imaging that you've done intra-procedurally will tell you exactly how deep the needle needs to go. And real time, as you're advancing the needle, you can image and see exactly where the tip of the needle is. Once you've hit the lesion, you can then place a coil and place a breast localization needle and make a targeted incision, usually 1 interspace below. Place a soft tissue retractor. And then use a stapler to resect the lesion. This is what the resected segment of the lung looked like, and we image it, and you can see that this is the coil that is within it with the breast localization needle, and you may be able to appreciate the actual nodule itself. Pathology was performed. Frozen section confirmed this to be a granuloma. So this is an example of adapting existing technology to new users. It improves the flow of the procedure, single stop, reduces the cost to the patient because there's no radiology billing, and greatly increased patient convenience and comfort. Thanks.
What do you do? You mentioned getting the arms out of the way, basically. You prep the arm, like if you want lines, you get lines in the cases with the coming from both arms, and everybody wants them out, and then you do the spin. You prep everything and put them in, and then spin them and bring them back out. I mean, that maneuver slowed us down a lot.
Yeah, I mean, so that's taken some evolution, and we don't actually do them all the same. First of all, you got to decide where the lung lesion is. I mean, this is kind of me talking as a vascular surgeon. You want to know what the approach is going to be. In a big patient, it's very difficult to put them up in the thoracotomy position because you have to tuck them in real tight. Yeah. Well, if the approach is going to be here and you've got their arms tucked here, that's impossible to do that. Yeah, so that's bad, and that's called a complication if you tear their arms off during the. They usually notice that if they go back with one arm missing. So Depending upon where it is, we make a decision whether we can put the patient in the thoracotomy position or the position where the thoracic surgeon is going to actually work on. And if we can't, we just put them supine. And we will localize them supine with the needle coming out and then reposition them. There are staff from the hybrid room back there. This is one of the more difficult things to manage actually when we're doing that. But they've kind of got the lines down. And we've kind of got wrapping the patient circumferentially. So we either will put the patient supine, localize it with the optimal position for localization, then move the patient, once it's localized, to the optimal position for the resection. If you can do it all in one, so much the better. But you can't always do that.
So we do most of our work in biplane, and so we have the same problem. Once we move the biplane in, and if the patient's on general anesthesia, every time we move the biplane out, we have to disconnect the patient from the circuit. Right, so that makes it very challenging. So that's where the 2D, 3D registration has become very powerful, right? So if you can actually take just two views, just LAO and RAO, and register based upon that, that makes it a lot easier than having to do a rotational angiography every time you want to co-register. Now, the problem is, of course, if you're only doing 2D, 3D registration, you have to have a landmark that's very close by to where you're actually going after. So if it's a small lung nodule, you need to have something that's very close by that you can register to your 3D data set. Otherwise, you may have some discrepancy in location. So that's the one caveat.
So the other thing that we didn't mention was respiratory motion. It's amazing, actually, because the lung moves differentially depending on what part of the lung you're actually in. And so lower lobes, diaphragms going up and down like this. I mean, there'll be an excursion that's pretty dramatic. So what we try to do is acquire first of all, if you can see the lung nodule on the cone beam in the procedure room, it's great. If you can't, and you have to import and fuse a scan, then it becomes much more complicated as you move these patients around. But in general, as Mahesh said, you can usually see these lung nodules. So then what we do is we acquire the cone beam with 20 millimeters of mercury inflation pressure. So we use the same inflation pressure to do the imaging, and then every time we advance the needle, we go to the same inflation pressure to try and correct for that respiratory motion.
Yeah, we have found that in some areas, and particularly the basal areas, because of the increased excursion, this is, it doesn't always work as well as it does in the upper or the mid areas. And in terms of repositioning, really lesions that are located very far anteriorly or very far posteriorly are the ones that require us to, image first supine and then position the patient as we would for the resection.
The one issue we had in one patient is we got a pneumothorax. We didn't recognize it. So we're like, fire the coil, and it goes, what? Then we just looked again. So you always look to see if there's a pneumothorax. That's the only time there's been a pneumothorax, but that would certainly change the localization. And, one case where we had to there's another nodule we had to go after, and we did that after the first lung nodule had been resected. So the lung and the chest had been entered, the lung was collapsed. We reacquired the scan. You could actually see the other lung nodule, and we just relocalized it, and it worked out fine. But you've got to recognize if you've changed the anatomy of the lung, either by resection or by the pneumothorax that's present. All right, thank you. Thank you, Mahesh.